Hello friends, welcome to Shreyatralay. This case, we are performing phacoemulsification in a small pupil, grade 2 to 3 cataract. We have taken a half entry rather than a full entry for a main port so that stable chamber we will get while performing the rhexis. A side port of 23 gauge is made, and now we will stain this particular capsule, especially under the iris also. So a adequate amount of trypan blue is injected into the anterior chamber, also below the iris, and capsule is stained well. It takes almost 30 seconds to have a good stain of a capsule. Now once capsule is well stained, a 5.5 mm rhexis marker is used to have assessment of rhexis size. Anterior chamber is filled up with viscoelastic and a rhexis with 26 gauge needle is started in an anti-clockwise direction and tried to have a larger rhexis so that while managing small pupil we will not face issues due to smaller rhexis also. So it is better idea to have a slightly larger size rhexis whenever you are operating in small pupils. Rhexis is completed and the flap of rhexis is taken out. That is very crucial because that may hinder sometimes the visibility. And now I am going in and making my incision complete, that is 2.6 mm in this particular case. Chamber is well formed. A hydrodissection and hydrodelineation are very important steps. Here I am using a Epsilon EP71 side cut chopper. No financial interest though. So I am rotating the nucleus slightly and taking the cortical material so that I can have a less amount of tissue left behind in the bag, and manipulation of nucleus becomes easy because of the debulking of bag. So once it is achieved, bag is well free. I am engaging the nucleus for the first chop and taking out it slightly out so that I can see a equator and then chop it. So you can see first chop is very well made. Now we will attempt the second chop, making it into further small pieces. This we have taken a very small piece so that we can divide the second piece into multiple small pieces, and rather than waiting to divide the further heminucleus into further pieces, I am just taking out these small heminuclear pieces which are already ready to be taken out. So once that is done, I am taking in my left hand instrument and rotating the nucleus so that I can have a good position of all nuclear fragments, and I need not to move my phaco handpiece much. Once that is done, you can see each piece is well taken into small pieces, divided into small pieces and then taken out. Chamber was slightly shallow and the position of nucleus was also slightly disturbed, so I have decided to take out the phaco probe and reform the anterior chamber and position the heminucleus so that I can manage it well without any issues. There is no need to hurry in such scenarios because these are very sensitive cases and can have issues at any particular moment. Even though we have completed more than 70-80% of the case, it still can have complications. Again, I am going in with phacoemulsification, dividing it, and once I eat away my nuclear pieces, I take my left hand out or take it to the periphery so I should not inadvertently damage the posterior capsule if AC becomes shallow, in case something like that happened. So thereby the nucleus is over and chamber is again formed with viscoelastic. We will take away the cortical material now I usually use a coaxial irrigation aspiration probe. So I am going in, taking all the cortical material. There was not much cortical material, but coaxial irrigation aspiration I particularly love it, and that takes it very fast. Again, the chamber is very well formed, and now we will load the IOL. Here I am using a Hoya IOL, which is a preloaded system, and it is one of the very fine preloaded system. You just have to inject a visco into the cartridge of a IOL and push the cartridge slightly forward. That way IOL gets loaded and it is ready to be implanted. This is one of the very good systems which I really like, though no financial interest in the product per se. So I am going in and injecting the IOL in the bag. The first haptic goes directly to the bag, the second haptic goes to the anterior chamber, and thereby we can dial this second trailing haptic into the bag. The IOL is gone in bag now, and visco is taken out with the help of irrigation aspiration cannula. I hope you like this particular case, and not touching the peripheral areas, not going to the periphery and staying your phaco probe in the center is very crucial important tip, and to have a stable chamber is very crucial. Hope you enjoyed this. Do subscribe to YouTube channel Dr. Pankaj Lande for more such exciting videos. Thank you and good day.